All right, welcome back. Part 2 of our CPR2 exam review. We're talking about renal anatomy and physiology, germ layers. So your kidneys and ureters, they are derived from mesoderm. When we're thinking about epithelium, think about endoderm. So mesoderm, muscles, right? Endoderm, epithelial layers of your bladder and urethra. The kidneys and ureters are developed from a succession of events that involve the appearance of your renal precursors, your pronephros, mesonephros, and metanephros. We're going to talk about those three renal precursors in the next couple of slides. Your urinary bladder and your urethra, they are derived from your cloaca. So this is a communication between the surface ectoderm and your allantois. It is divided by a urorectal septum. The ventral portion develops into the bladder and urogenital sinus. The dorsal portion develops into the rectum and anal canal. And the trigone of the bladder is derived from your mesonephric ducts from the mesoderm. So look at the urinary system development first. Weeks 4 to 5, we have overlapping excretory systems. There's 3 systems that develop with intermediate mesoderm. They overlap chronologically. First, we have the pronephros. It is non-functional and it completely degenerates. After this, we have the mesonephros, high yield. This contributes to the male reproductive tracts. And your metanephros, high yield. This is your definitive kidney. They develop continuously postnatally. So week 6, we have the kidneys ascend. If the kidney is trapped, right, in your inferior mesenteric artery, what do we call that? Horseshoe kidney. If the kidney can't ascend because it's trapped in between your inferior mesenteric artery, we call that horseshoe kidney. So it ascends. So the left kidney is higher than the right kidney. Why? Because the right kidney has the liver in there. So it's a big portion. So the right kidney is much lower than the left kidney. Also, there's an important association with the vein on the left side, the left renal vein. What is it? In males? Can someone tell me? In males, the left renal vein is very, very important. Why?
It drains directly into the left something. I just can't remember.
Left gonadal vein. Excellent. So that's it. If we have a compression there, it's only on the left side. So left gonadal vein drains into left renal vein. Left renal vein drains into inferior vena cava. Week 7, we can have incorporation of the ureteric bud. Remember, the ureteric buds and mesonephric ducts are incorporated into the posterior bladder wall. However, we are focusing on the 3 pre-renal stages here, the pronephros, mesonephros, and metanephros. So pronephros, there's nothing important there. Why? It degenerates completely. Nothing there. Mesonephros, don't forget that the cranial end, as from the Bowman capsule, it degenerates. However, the caudal end, this develops into the mesonephric duct, which forms the epididymis, ductus deferens, seminal vesicles, and the ejaculatory duct in male embryos. So male reproductive system from your mesonephros. Metanephros it forms the structures of your kidney, composed of 2 parts, high yield ureteric bud and metanephric blastema. From the glomerulus up until the distal convoluted tubule, this is from your metanephric blastema. Or they're going to put metanephric mesenchyme. It's the same thing. From your collecting duct up until your ureter, it comes from your ureteric bud. Okay, that's high yield. Again, the structure of your kidney here, we have your nephron, and here we have your renal corpuscle, we have your afferent arteriole, glomerulus, and we have your efferent arteriole. Where is it located? Retroperitoneum. Next term, we're going to learn about all of the retroperitoneal structures in the abdomen. So projected laterally to thoracic 12 to L2 to L3. The right kidney is about half a vertebra lower than the left. Why? Because of the liver. So cranially, above the kidney, we have the adrenal glands. Don't forget, adrenal glands is essential for your catecholamine synthesis, right? Specifically, you have your glucocorticoids, mineralocorticoids, which is produced in the adrenal cortex, and then in the adrenal medulla, we have your sex hormones. Caudally, we have the flexure of the transverse colon. So anteriorly on the left kidney, we have the stomach, the spleen, pancreas, the tail, the right kidney, the right hepatic lobe, and the descending part of the duodenum. What's the size? 10 to 12 centimeters long. What's the weight? 150 to 180 grams. So we need to know the anatomy of the kidney anteriorly from the superficial layer up to the deep layer, right? So in the deepest layer, you have the renal medulla. Consists of 7 to 12 medullary pyramids. It contains the loop of Henle and the collecting duct. We also have the renal cortex, the outermost layer of the renal parenchyma. The cortex columns extend into the medulla. So your cortex, it contains the glomeruli, ECT, DCT, and renal vessels. The renal pelvis, it connects to the ureter. You have the minor and major calyces, and it forms the ureteropelvic junction. The kidney is also surrounded by a renal capsule. It's a very tough fibrous structure. It lies anteriorly to the surface of the renal cortex. You can also have fascia there. The fascia, why? We need to protect the adrenal glands. That's why you have the renal adipose capsule. And of course, if the fascia is inflamed, you can have pain or any urinary obstruction, outflow obstruction, or swelling of the kidney. Can induce strain on the renal fascia, thereby producing pain. High yield, put a star here. Know the blood flow, the arteries, right? So renal artery goes segmental, interlobal, arcuate, interlobular. Then from interlobular, you have the afferent arteriole to the glomerulus, efferent arteriole to the peritubular capillaries. This is your vasa recta. Your peritubular capillaries are engulfing your nephron here. So we have your glomerulus here, proximal convoluted tubule, descending limb of the loop of Henle, ascending limb of the loop of Henle, distal convoluted tubule, and then you have the collecting duct here. Know the blood supply, please. It all drains into the renal vein in the end. Again, know the blood supply, know the venous drainage. This is your nephron. So we have the Bowman's capsule, as I've said, ECT. Most of the reabsorption happens in your proximal convoluted tubule. We have the descending limb of the loop of Henle. Remember, we are now in the medulla, the renal medulla. So this one, we are concentrating the urine. So we are reabsorbing water here in the descending limb of the loop of Henle. And then we go to the thick ascending limb, the loop of Henle. This part is impermeable to water. We are reabsorbing the solutes here. And then the DCT, aldosterone, works on your DCT. And then the collecting duct, your antidiuretic hormone, works in the collecting. So what is a nephron? What does it do? It's a functional unit of your kidney. We talked about the flow of urine from the glomerulus to the PCT, to the loop of Henle, DCT, collecting tubule, and to the collecting. What's the function of your renal corpuscle? There are two parts, glomerulus and the Bowman's. The glomerulus, it's a tuft of capillaries within the Bowman's capsule. It is composed of your afferent arterioles, your capillaries, and efferent arterioles. The Bowman's capsule is just that thing that surrounds the glomerular capillaries. We have podocytes there, right? It merges with your proximal tubule. Again, high yield. This is your glomerular filtration barrier. What's the function of the glomerular filtration barrier? It's a size barrier and a charge barrier. Can albumin normally pass through the glomerular filtration barrier? Yes or no?
No,
No. Why?
because it has a negatively charged.
Excellent. So negatively charged molecules, they cannot pass through the GFP. How about size? If it's a bigger molecule, it can't pass through. High yield, no. The GBM, it just consists of 3 layers. They're gonna give you a slide, a histology slide for this. Know them. So lamina rara interna, it's internal, right? So it covers the endothelium itself. Lamina densa is a central dark zone. It consists of collagen type 4 and laminin. Type 1 collagen, where can we find type 1? Type 1 collagen, where can we find it?
Type 1 doesn't exist, isn't it?
So don't forget K-pop, BTS, bone, tendon, skin. How about type 2 collagen? Type 2 collagen. Where can we find type 2 collagen? You can Google it if you want to. Basically, eyes. 2 eyes. Type 2, you have the eyes. Type 3 collagen.
Reticular fibers.
Reticular fibers. Give me a pathology that's associated with type 3 collagen.
Would that be Marfan's or anything like that?
Careful. No. Careful. ED, Ehlers-Danlos. Type 3. Remember, there's 2 types, type 3 and type 5. Type 3 is the vascular type. Why? It's much more deadly because the aorta is made up of reticular fibers. You can develop aortic aneurysm. It can blow up, right? And type 5, Ehlers-Danlos, it's normal. You can have hyperextensibility of your joints, basically. Give me a pathology associated with type 1 collagen. Type 1 collagen. Deficiency in type 1. The eyes, choroidal veins. What is this? What are we thinking? Type 1 collagen, defect. What's this? Osteogenesis imperfecta, type 1 collagen. Remember, with the eyes, it's blue sclera. Why? Because you can see the choroidal veins. Okay, just for now, integrate the materials. Don't forget those basic one from FTM1 and FTM2 because it will going to haunt you back for the next term. Okay, so lamina densa, type 4. Basically here under the floor, I've said basement membranes, typically type 4. And laminin and lamina rara externa, you have podocytes. And the heparan sulfate. Don't forget that the heparan sulfate, it repels your negatively charged glycoproteins. Clinical relevance, did you talk about anyone here, the Goodpasture and Alport syndrome? Did you talk about this or no?
No, I don't think so.
No, all right. That's for term 4 then, even the minimal change disease. Again, PCT, what can we see there? It's a tall epithelial cells with brush border. You have microvilli. It contains lysosomes. We talk about the loop of Henle. The descending loop of Henle, it's permeable to water. We are concentrating the filtrate, and the thick ascending loop of Henle, it's impermeable to water. We are reabsorbing the solute. The distal convoluted tubule, don't forget aldosterone, the hormone that affects your distal convoluted tubule, specifically the distal part of the distal convoluted tubule and the proximal part of the collecting duct. But for my sanity's sake, I always associate aldosterone with the distal convoluted tubule. Collecting duct, think of antidiuretic hormone, connecting tubule and your connecting duct. All right, here we have the juxtaglomerular apparatus. Let's talk about renin synthesis. So if someone stabs me, I'm bleeding out, so hemorrhagic shock, or if I'm dehydrated, right? Or if I lose my electrolytes, what happens? Oh, by the way, guys, did you talk about the urinary system yet or no?
Yes.
Okay, so if I have hypovolemic shock, hemorrhagic shock, if I have low electrolyte count in my blood, what happens to renin? Increase or decrease?
Increase.
Increase in renin. So your macular densa cells, we're going to say JG cells, hey, wake up. We need more renin. The JG cells obliges, and then it produces renin. Where does it go, the renin?
It activates the adenosine to
Okay.
adenosine 1. But
Excellent, good job. So where do you produce, what organ produces angiotensinogen?
Liver.
Liver, excellent. So the renin goes to the liver and it activates angiotensinogen 1 to angiotensinogen to angiotensin 1. Then angiotensin 1 needs to be converted to angiotensin 2 by what enzyme?
Is it the ACE enzyme?
ACE enzyme. What organ produces your ACE?
The lungs.
Lungs, excellent. And then, don't forget, your angiotensin 2, it's a potent vasoconstrictor or dilator? Angiotensin 2, potent. Remember the scenario that I've laid out? Hypovolemic shock.
Constrictor.
Constrictor, excellent. We need to increase that blood pressure. So vasoconstriction, right? So what happens to aldosterone? We also increase the level of aldosterone, and then we are reabsorbing the sodium. When sodium is reabsorbed, water follows. So we're reabsorbing sodium and water. Excellent. Please know that pathway that's a very, very high yield. So this is just your JGA apparatus. So you have your glomerular stereo, you have the Bowman's capsule there. You have the efferent arteriole. So what is this? What are the parts? Macula densa for hypoosmolarity. Remember, hyposmolar urine triggers the release of renin, right? Which causes vasoconstriction of the efferent arteriole, which increases the GFR. The JG cells, they are the ones who synthesize renin. Don't forget, high yield juxtaglomerular cells are the one who synthesizes your renin. What's the function of the kidneys? Elimination of waste, regulation of electrolytes, hormone synthesis, high yield EPO, right? Function stimulates RBC production in your bone marrow. It is inducible by what? Don't forget HIF, hypoxia inducible factor. When you have decrease in oxygen saturation in the blood, decrease in partial pressure of oxygen in the blood, you have an increased production of your HIF, which increases the production of your erythropoietin, which increases the amount of RBCs. Okay? Also, don't forget, calciferol is in your kidneys. Tell me about vitamin D synthesis. Vitamin D. So how are we synthesizing vitamin D in the body? So we have So remember, we have cholecalciferol to 25, dihydroxycholecalciferol. What enzyme converts that in the liver? (25) hydroxylase, and then 25 OH D3. It goes to the kidneys, and it will be converted to 125 OH D3 via what enzyme? 1-alpha hydroxylase. What's the function of your parathyroid hormone?
Increase calcium.
Increase calcium. So where does it act? Does it act on the 25 hydroxylase enzyme in the liver or the 1-alpha hydroxylase in the kidneys? How does it increase calcium levels?
The kidneys.
In the kidneys. So calcium reabsorption in the DCT and phosphate wasting in the PCT. Those are high yield. You are increasing calcium levels, yes, because you are increasing the activity of your 1-alpha hydroxylase to convert calcidiol, your 25 OHD3, to 125 OHD3, to calcitriol, right? You're also increasing calcium. However, you are wasting potassium. You are wasting phosphate in the process of increasing the calcium levels. So PTH, think phosphate trashing hormone. Phosphate trashing hormone. We talk about prostaglandins also. It maintains renal blood flow. Prostaglandins typically dilates or constricts what arteriole? Does it dilate or constrict? The normal function of
Dilate the afferent arterioles.
excellent. Think PDA. Prostaglandin dilates afferent arteriole. PDA. That's a normal prostaglandin. Also, you're going to learn term 4 that dopamine can also dilate their afferent arteriole. Again, hypoxia, kidney is a sensor, increase HIF, increase EPO, there we go, and then increase erythrocytes. Sometimes it is abused by athletes, okay, to increase the oxygen in their blood. So overview of urine generation, where does it go? From the glomeruli, it goes to the Bowman's capsule and the space, DCT, leukopenly, DCT collecting ducts. It drains into the minor calyces, major calyces, renal pelvis, ureter, bladder, and urethra, and then outside of the body. What are the ureters? They are retroperitoneal. They are smooth muscles. They connect your kidneys to your bladder. So a high yield constriction of the ureters in 3 points. They are why? These parts, they are prone to stone impaction. So if you don't drink water and if you like salty foods, you have an increased risk of developing urinary kidney stones, right? So 3 parts. Uretero-pelvic junction in the kidneys, because these are narrow portions of your anatomy. Pelvic inlet, this is the one where it crosses the external iliac arteries. And your ureterovesical junction, where it enters the posterior wall of the urinary bladder. Again, high yield constrictions of the ureters, where ureteropelvic junction in the kidneys, pelvic inlet, where it crosses the common iliac, and the ureterovesical junction, where it enters the posterior wall of the bladder. What's the innervation of the ureters? Lumbar splanchnic nerves. For sympathetic, for parasympathetic innervation, pelvic splanchnic nerves. I need to know the arteries, middle yield, ureters, the renal arteries for the veins, renal veins. Of course, the pelvic part is the branches of the common iliac and internal iliac, and the veins, branches of the common iliac and internal iliac veins. This is your water and under the bridge. It's a good image. Remember that the ureter travels posterior to the one of the arteries, and it travels anterior to the common iliac arteries. External iliac artery at the level of the bifurcation. Okay, so this is your water under the bridge. So be careful when you cut. For example, in females, be careful when you're doing ligation of your ovaries. Why? Because you might cut the uterine artery and you might cut the urethra. When you're doing vasectomy in males, careful because this the urethra is anterior to your vas deferens. So if you cut the vas deferens, be careful, you might cut the urethra. Okay, that's the clinical relevance of your water under the bridge. So this is a good histology image of the ureter. What kind of epithelium? High yield transitional epithelium. Are there layers? Yes. Do they contract? Yes. Do they relax? Yes. So in a peristaltic manner. So you have an inner longitudinal, outer circular, and then outer longitudinal layer. This is your bladder. So ureter is coming in posteriorly. Then this is your bladder. We have the opening of the ureter here. This is the trigone. And then you have the internal urethral orifice. External urethral orifice can be found here. And then this is your urethra. What's the function of the bladder? So it's a hollow, triangular shaped organ. It is located extraperitoneal, behind the pubic symphysis. It can hold your urine. That's the function of it. So sensation of bladder fullness is felt at 300 to 500. It contains smooth muscle. Don't forget that the detrusor muscle of the bladder contracts when you go and pee. Don't forget also that the rupture of the bladder can happen, especially when the bladder is full, and it can cause peritonitis, inflammation of your peritoneum due to the extravasation of the urine into your peritoneal cavity. What's the innervation of the bladder? High yield, put the star here. Sympathetic, it causes relaxation of the detrusor muscle and constriction of the internal urethral sphincter. This is for retention of urine. You're in class, you're listening to the lectures, you wanted to pee, you want to hold your pee, sympathetic kicks in, the detrusor muscle is relaxed, internal urethral sphincter is constricted, you can't pee, retention of urine. After the lecture, I wanted to go to the restroom, I wanted to pee now, increased parasympathetic innervation, pelvic splanchnic nerve, S2, S4, detrusor muscle contracts, internal urethral sphincter relaxes, you empty your bladder. High yield. What's the lymphatics? Internal iliac and external iliac nodes. We talk about the detrusor muscle, which constricts during bladder emptying and relaxes during retention of your urine. This is controlled by parasympathetic nervous system. And the internal urethral sphincter is controlled by sympathetic nervous system. It constricts during retention of urine when you don't want to pee, and it relaxes when you want to pee, for emptying of the bladder. Those are arteries. Just know that they are supplied by the branches of the internal iliac arteries. And for the veins, they're supplied by branches of the internal iliac. Again, look at the dome of the urinary bladder. High yield, what's the epithelium here? Look at the epithelium. Transitional epithelium. So when the bladder is full, this layer, transitional epithelium, they become much flatter and much thinner. You also have 3 muscular layers: IOL, MCL, OLL. What's the difference of the urethra between male and female? Male has a longer urethra. It also divided into 3 parts: prostatic urethra, membranous urethra, and spongy or penile urethra. So question, is that significant? The female urethra is shorter than the male. Is that significant? Yes or no?
Yes.
Why?
UTIs?
Excellent. So female has more prone to UTIs because of that shorter urethra. Okay? Again, don't catheterize someone. Don't put a Foley catheter in patient with suspected urethra injury. For example, you're going to learn next term about the anterior urethral injury, posterior urethral injury. You have high riding prostate, that's posterior. Butterfly hematoma, you have the anterior urethral injury. More of that next term. In males, do I need to know the arteries and veins? Well, they mirror each other. So they're all part of the vesicle arteries. In females, you have the pudendal arteries and the pudendal veins. I think that's it. Not too specific here. Look at the urethra. What's the epithelium in males? Transitional. In the prostatic part only. In the membranous and spongy, it's stratified columnar epithelium. You have muscular layers, of course. In females, it is not divided into 3 parts in females. It's just one. It is made up of a stratified squamous epithelium, and you have some muscular layers there. So aside from the length of the urethra, in males, it is divided into 3 parts. Okay, don't forget that. In females, it's much shorter and it's only 1 part. Then we talk about this one, about renin. How do we produce urine? So the site is a nephron. So we have the glomerulus, which is the major filtration structure, and the tubules. What's the process? Blood flows into the afferent arteriole, into the glomerular capillaries. Then it is filtrated across the GFB. Don't forget your lamina raris there, into the urinary space within the Bowman's capsule. This is where the primary ultrafiltrate is formed. Once it passes within the Bowman's capsule, your primary ultrafiltrate is now formed. Then this one, it flows through the glomerulus, through the tubular system. It is finely tuned for reabsorption and secretion of plasma components. Don't forget, approximately 99% of the filtrate is reabsorbed in the bloodstream, commonly reabsorbed in the proximal convoluted tubule, and then you have urine is formed, and then urine flows into the collecting duct, to the renal pelvis, to the ureter, bladder, urethra, and outside of the body. Again, look at this image here. So we have the glomerulus here, ultrafiltrate is formed, proximal convoluted tubule, most reabsorption is here, sodium reabsorption, potassium reabsorption, magnesium reabsorption, all of the reabsorption, 75%, happens in the proximal convoluted tubule, water reabsorption also, and then we have the loop of Henle, we have the thin descending and the thick ascending. Here we are in the renal medulla. So as we go down in your descending loop of Henle, this is permeable to water. Water is being reabsorbed. We are increasing the concentration of the solute, right? So typically here, milliosmoles, let's just say 500 here. When you go here at the end, the solute concentration is like 1,000. So we are concentrating that filtrate, right? Ultrafiltrate. And then when we go to the thick ascending limb, what happens? This is impermeable to water. So we are going from 1,000 milliosmoles here to probably back to 250 milliosmoles in the renal cortex. We are reabsorbing back the solute here, the thick ascending limb of the loop of Henle. Then there's still collecting tubule. Some reabsorption still happens. Remember, 99% is reabsorbed, right? And then to the collecting duct. All right. Let's go to the nitty-gritty of everything. So this is just like anatomy, right? Afferent, proximal, all of those that we talked about. So physiology, renal blood flow, the blood flow that flows through the kidney per unit of time. Renal plasma flow, the volume of plasma that flows through the kidney per unit of time. The PAH, para-aminohippuric acid, this is used to estimate your renal plasma flow. Why? Because it is completely filtrated and secreted, your PAH. Now, you might ask, Nick, do I need to know the formula? Of course. You need to know the formula. But like I've said, in your lung anatomy and physiology review, only one variable is missing. So it's simple single variable algebra. So you just to manipulate the formula. Okay? Know the formulas. Prostaglandin dilates the afferent arterioles, and you have your angiotensin. Angiotensin constricts your efferent arteriole. Angiotensin 2. So PDA and ACE. P, prostaglandin. D, dilates A, afferent arteriole. And then ACE, angiotensin 2. C, constricts E, efferent arterioles. That's the mnemonic that you need to know. We talked about the renin-angiotensin system. Put a star here. This is very high yield. Now, let's talk about, we talk about aldosterone, right? So low sodium, hyponatremia, you need to absorb more sodium. So renin, angiotensin, aldosterone system to increase sodium levels in the blood. Where sodium goes, water follows. As you're reabsorbing the sodium, the water is also reabsorbed. Now, I want you to think two hormones, collecting duct. Think about antidiuretic hormone. By the name alone, what can you imply? Antidiuretic hormone. What can we imply by the name alone?
Anti-diuresis, I always look at it like you're eliminating water. So if it's anti-diuretic, means it's stopping you from eliminating the water.
Excellent. So this is, you are no antidiuretic hormone, you are not peeing, you are not wasting water. Example, if you're stuck in a desert, right? You don't have any water, so you have increase in your ADH. Where is it stored in the body? Anterior pituitary or posterior pituitary? So posterior pituitary. Actually, it is produced in the hypothalamus and stored in the posterior pituitary together with your oxytocin. More of this next term. So antidiuretic hormone. So it increases contraction of your smooth muscles via V1 receptor. Where can you find V1 receptors? Blood vessels. Specifically, where? What's the major regulator of blood pressure? Arteries or veins?
Is it the arteries?
Excellent. Specifically what? Major regulator of blood pressure. If it constricts and dilates, it might increase or decrease your BP.
Is that the arterioles, I believe?
So it is the arterioles.
Artery.
Forget arterioles, they're the primary regulator of your blood pressure. So you have the V1 receptor there. So if I increase contraction of the smooth muscle in the blood vessels via the V1 receptors, because you also have V2 receptors. V2 receptors are found where? In your nephron. Where can we find the V2 receptors in the nephron? What part of the nephron? So collecting duct, don't forget, you also have V2 receptors there. What cell? What cell in the collecting duct? Guys.
Is it the intercollected cells?
No, the alpha intercalated cells is for H+. Careful. Principal cell. Remember the principal cell? Excellent. AS. It's the principal cell. So it increases free water reabsorption in the collecting duct. Increase the cyclic AMP, you have increased aquaporin in the luminal membrane of the collecting duct. This increased aquaporin in the collecting duct will gonna increase water reabsorption. So that's your anti-diuretic hormone. You're lost in the desert. You need to conserve water. ADH is increased, right? It increases free water reabsorption in the collecting duct via what mechanism? GS, increase in cyclic AMP. When this is increased, what happens? More aquaporin is produced in the luminal membrane of the collecting duct. Thereby, you are reabsorbing more water. Okay, that's your antidiuretic hormone. Question, guys. A pathology. Give me a pathology that involves your ADH that you know. Did you talk about syndrome?
SIADH.
Ah, excellent. Syndrome of inappropriate ADH. Dilute urine or concentrated urine? What's the urine osmolarity of syndrome of inappropriate ADH? Dilute urine osmolarity or concentrated urine osmolarity?
Dilute.
Careful. Careful. Syndrome of inappropriate ADH. So it is concentrated. So you have a concentrated urine. You are wasting the solutes, right? Contrast this one with diabetes insipidus. What kind of urine osmolarity you have in diabetes insipidus? This is dilute urine. Diabetes insipidus. So I want you to know that. So if in DI, diabetes insipidus, it's dilute urine, what happens to the serum osmolarity of all your solutes, of your sodium, potassium, magnesium? What happens then? It is, what can you infer from that information alone? You have a dilute urine, you're wasting water. What happens to the serum concentration of your solutes?
It should go up.
It should increase. Excellent. Good job. Contrast that with the SIADH, concentrated urine, right? So you are wasting the solute. What happens to the serum concentration of your ions in the blood? It goes down because you're wasting them, okay? Did you talk about the differences between nephrogenic and central diabetes insipidus or not yet? Yes, no?
We did.
You did. Okay. Tell me, how are we going to differentiate central DI from nephrogenic DI?
I think when you give the what was that? There's a medication. There's a hormone that acts at the level of the kidney.
Good job. Excellent. So you give exogenous vasopressin. So if you give exogenous vasopressin in central diabetes insipidus, the urine becomes concentrated after a couple of hours. So when you recheck the urine, it becomes concentrated. That's central DI. Why? Because in central DI, you have no production of antidiuretic hormone. How about in nephrogenic diabetes insipidus? When you give the exogenous vasopressin, nothing changes. When you recheck the urine, it's still dilute. Why? Because V2 receptors are missing. They are downregulated in your nephrogenic diabetes insipidus. So I want you to think about those two conditions. Compare and contrast diabetes insipidus versus SIADH. Compare and contrast central diabetes insipidus versus nephrogenic diabetes insipidus. When you think of ADH, what hormone counteracts ADH? I want you to think A and P, atrial natriuretic peptide, and B and P. Okay, so this one, if you have a volume overload, you have congestive heart failure, right? Your body is overloaded with volume. We need to waste that volume. So A and P in the atria, it is produced in the atria. And B and P which is produced by your ventricles. Why is it called BNP if it is produced in the ventricles? Because it was first seen in the brain. That's why it's called brain natriuretic peptide. It should be called ventricular natriuretic, but you know, in medicine, ANP and BNP from the heart, meaning it counteracts the effect of your aldosterone, renin, ADH, and adrenocorticotropic hormone. Okay, ADH, desert, there's no water, I need to conserve water. Natriuretic peptides, ANP, BNP, I have too much water in my body. I am volume overloaded. I have congestive heart failure. I have pulmonary edema. I'm volume overloaded. I need to waste those water. Okay? Good job. Compare and contrast these two. Put a star here. This is how you. So, autonomic regulation. If noradrenaline is there, it binds to A1 receptors, alpha 1, GQ, GIGS. GQ, GI, or GS.
Is it GI?
Careful. GQ, right? KISS. KISS, don't forget GQ. Right? Phospholipase C, PIP, IP3DAG, protein kinase C. Vasoconstriction of your arterioles, increase resistance, you decrease the renal blood flow. Don't forget also dopamine. It binds to D1 receptors, it dilates your arteries, and it decreases the resistance, thereby increasing renal blood flow. What's the take-home message? If I increase sympathetic nervous system, if I increase noradrenaline, you are constricting the arterioles, you are decreasing the renal blood flow. Dopamine is the opposite, right? If I increase dopamine, I vasodilate my arterioles, I increase my renal blood flow. Don't forget this. Most of the total body water is 60%, ECF is 20, intracellular is 40. Know the percentages, please. Just plain memorization. Know the percentages of each, okay? Talk about the fluid compartments. This is just, so 60, 40, 20 rule refers to the total body water. This is a trick. 60, 40, 20. 60 is 60% body mass, right? It is composed of water. So 60% of us, of our body mass is composed of water. 40% of that body mass is ICF, intracellular fluid. And 20% of that body mass is ACF, extracellular fluid. Okay, don't forget that one. We're talking about clearance here. What is clearance? The volume of plasma is cleared of a substance per unit of time. Do I need to know the formulas? Of course, you need to know all of the formulas, please. AH, your creatinine, inulin, and your glucose. GFR, what can we use to estimate GFR? What can we use to estimate the GFR?
It's going to be inulin.
Yes, inulin. Yep. Creatinine also, but it's tricky. It's tricky to use creatinine, but mostly in the lab we use creatinine. All right. How about EPF? Effective plasma flow. What are we going to use for effective plasma flow? We use PAH. Okay, don't forget that one. So clearance, yada yada yada. Please know the formula. Okay, GFR. We're talking about glomerular filtration rate. Question. So the question will gonna be application. Remember the PDA and the ACE that I talked to you about, the mnemonic. If I give someone NSAID, it inhibits cyclooxygenase 1 and 2. Irreversible inhibitor, like aspirin. I give aspirin. irreversible inhibitor of COX-1 and COX-2. No production of prostaglandin. What happens now to my afferent arteriole? What happens now to my afferent arteriole? Anyone?
If we're increasing GFR, we'll be vasodilating the afferent.
So if we are giving aspirin, we are constricting the afferent arteriole, thereby decreasing the renal blood flow, right? The renal plasma flow, and decreasing the GFR. If I give, for example, an ACE inhibitor, like lisinopril or captopril, so the questions are going to be application, guys. Okay, application questions. So if I give captopril, lisinopril, your ACE inhibitors, what happens to the efferent arteriole? Constrict or dilated?
Now those are going to dilate.
Excellent. You're going to dilate. What happens to the renal plasma flow? Increase, right?
Yeah,
you are
increasing
the renal plasma. But what happens to the GFR?
Decrease.
Decreasing GFR. Excellent. So the rate at which GFR is the rate at which fluid is filtered by the kidney. Do I need to know the specific formula here? Like glomerular, capillary, Bowman's space, hydrostatic. Sometimes they put this one of the answer choices, like how to calculate GFR. So please know this. You can also use this formula to calculate GFR. All right, we'll talk about inulin. What's the relationship between the inulin and urine concentration? It's linear. So why? Because inulin is really filtered and neither reabsorbed nor secreted. So the amount in urine of inulin in your urine, it represents the amount that is filtered by the kidney. So this is very good in doing your GFR. Inulin clearance, don't forget, do I need to know the formula? Of course, you need to know the formula. Urine concentration times volume divided by P of inulin. Then to get the concentration of your inulin. Okay, another way to estimate GFR, aside from inulin. Clinically, we use creatinine clearance. However, as I've said, it overestimates your actual GFR. It's also age-related increase in creatinine, right? For those old people, they usually have high creatinine clearance. So be careful when interpreting the lab values. If you have an older patient, if they have an increased creatinine clearance. Talk about PAH. What is this? PAH is freely filtered, not reabsorbed, and fully secreted. Don't forget those characteristics. After a specific plasma concentration, the saturation of the secretion mechanism starts, leading to a smaller increase of the urinary concentration relative to the plasma concentration. So PAH used to estimate your effective plasma flow, renal plasma flow. Why? Because it's freely filtered in the glomerulus and secreted in the tubular lumen. If the plasma concentration of PAH is low, it is completely excreted from the plasma through filtration and secretion. Inulin creatinine for GFR, PAH for effective renal plasma flow. How about glucose? How are we going to reabsorb glucose? Okay, so look at this. Look at the graph. Look at the abscissa. Abscissa represents the plasma concentration. The ordinate represents the urine concentration. So at 0.10, above 10 millimoles per liter, normally above 180 milligrams per deciliter, of plasma glucose concentration. Not all of them are reabsorbed. You're having glucosuria above 180 milligrams per deciliter, right, by the PCT. Don't forget high yield. The maximum secretion rate of glucose is 380 milligrams per minute. Okay, so glucose is not reabsorbed when all of the receptors are saturated with glucose molecules. You can no longer reabsorb glucose. The maximum secretion rate is reached, 380 milligrams per minute. The maximum glucose concentration is reached, which is 10 millimoles per liter or 180 milligrams per deciliter. Okay. When you reach those milestones, above that, you are experiencing glucosuria, which is glucose in the urine. You're urinating glucose, wasting glucose, commonly seen in diabetics. Right? Used to assess for glucosuria. Don't forget, glucose is reabsorbed and where? PCT, proximal convoluted tubule, via what? SGLT2. More of these transporters in next term. There's a glucose threshold, as I've said, 180 milligrams per deciliter. Above this threshold, the glucose is not reabsorbed. You also have a maximum reabsorption rate, 380 milligrams per minute. This is due to the amount of receptors that is expressed in your distal convoluted tubule, your SGL2 receptors, the amount there. If it is above this rate, it is no longer reabsorbed. If it's 400 milligrams per minute, no, we are wasting that glucose. Filtration fraction, high yield. What's the formula? GFR divided by RPF. Don't forget the regulation. We talked about this. Okay, the regulation here, put a star on this slide. Put a star here. You need to know what happens to the GFR, to the renal plasma flow and the filtration fraction. This is a nice slide. You can read that in your leisure. FENa. FENa is important. Put a star on FENa. Why? When you go to term 4, you're going to learn about the different diseases of the kidney, whether it's a pre-renal azotemia or post-renal azotemia. It is due to sodium. The percentages of the glomerular filtrated sodium that is excreted in the urine. So if this is used for acute kidney injury, whether pre-renal, post-renal, or renal kidney disease. Do I need to know the formula for FENa? For now, I think it's good for you to know, because when you go to term 4, this is important. Sodium excreted divided by sodium filtered, which is the following formula. You can read that in your leisure. Now, acid-base physiology. This is high yield. Let's paint a scenario. I just finished exercising. I am hyperventilating. What happens to my level of CO2 in the blood? I'm hyperventilating. Increase or decrease?
Does it increase?
So the PCO2, you're hyperventilating.
Oh, PCO2, not O2. Okay, yeah, it's decreasing.
Decreasing PCO2. So what happens to the pH? The pH also decreases, right? So what's the, how about in metabolic alkalosis? So hypoventilation. So let's look at this table then. Acid-base physiology. We have different kinds, metabolic and respiratory. We have compensation. First, you need to know what happens to the pH, what happens to PCO2, what happens to bicarb. There is always a compensatory response, okay? Probably term 4, you're going to learn about Winter's formula and how to differentiate the different metabolic acidosis. All right, but for now, this table is high yield. So hyperventilating immediately, right? Like right now, I'm having a panic attack, right? I'm having a panic attack, so I'm hyperventilating. What happens to the pH? It decreases. What happens to the bicarb in my blood? It decreases. What's the compensatory response? Is you are decreasing your PCO2. Okay. How about metabolic alkalosis? I'm hypoventilating. Okay, I'm obese. I have obesity hypoventilation syndrome. What happens to the pH in the blood? It's increased. It's alkalosis above 7.45, right? What happens to the bicarb? It's also increased. So what's the compensatory mechanism? I increase my PCO2. What if I'm having respiratory acidosis? Acidosis, pH is decreased below 7.35. What happens to my PCO2? It's increasing, right? Respiratory acidosis. I'm not hyperventilating. So what's the compensatory mechanism? You increase the bicarb. Respiratory alkalosis. Alkalosis, what happens to pH? Above 7.45. What happens to PCO2? It's decreasing. It's alkalosis. What's the compensation? Reabsorption. You decrease the bicarb. Reabsorption. So this is a good slide. Put a star here. How are we going to know in the vignette if it's the algorithm of how to know if it's metabolic, respiratory, if it's acidosis or alkalosis? First and foremost, check the pH. Is the pH above or low? What's the normal pH of blood? 7.35 to 7.45. That's the normal pH of blood. If it's below 7.35, it's acidosis. If it's above 7.45, it's alkalosis. Now you figure it out, right? What's the pH? Okay, let's look at, okay, if it's less than 7.35, it's acidosis. Now, check the CO2 and the bicarb. If the CO2 is more than 44, right, it is respiratory acidosis. Commonly seen in hypoventilation. You need to know the following: due to airway obstruction, acute lung disease, COPD, opioids, sedatives, weakening respiratory muscles. Right? If the bicarb is below 20, it's metabolic acidosis. You need to do another check. You need to check the anion gap. Know the formula, high yield. Sodium minus the sum of chloride plus your bicarb. And you need to check, is it more than 12 or normal? If it's more than 12, you have an increase on ion gap. Think about mud piles, high yield. Guys, memorize this now. This is important in term 4. Methanol, uremia, DKA, propylene glycol, iron tablets, lactic acidosis, ethylene glycol, salicylates. If it's a normal anion gap, there is no anion gap, then think about the following conditions: hyperchloremia, Addison's, RTA, diarrhea, acetolamide, a drug, spironolactone, it's also a drug, and saline infusion. That's your acidosis. If the pH is more than 7.45, think of alkalosis. Check first for your CO2. If it's less than 36, it's respiratory alkalosis due to hyperventilation. Know the following: due to what? Anxiety, panic, hypoxemia, high altitude, salicylates, early salicylate poisoning. That's the caveat there. Tumor and pulmonary embolism. If the bicarb is more than 28, it's a metabolic alkalosis. Due to what? H plus loss or bicarb excess, commonly seen in someone who's abusing loop diuretics, or bulimics that induces vomiting, or commonly using antacids or famotidine, or someone who has hyperaldosteronism. Okay, guys, after that, you need to know that, and then they're going to give you this wonderful Davenport diagram. Davenport diagram is to know whether it is respiratory acidosis, alkalosis, or metabolic acidosis and alkalosis. You just need to know where is the point. So the point is here. This is the normal. The buffer line is here. So if I move the buffer line on this side, this is respiratory acidosis. So we're going from 7.4 to this one, right? At my cursor, so it's 7.2, so it's acidosis. Look at the abscissa. Look at the ordinate, we're at 40, right? So above 40. So this is respiratory acidosis. Anything on this quadrant is respiratory acidosis. If we go here below, anything in this quadrant, respiratory alkalosis. How about this one here? Anything in this quadrant, metabolic alkalosis, and anything in this quadrant is metabolic acidosis. For now, they're not gonna play the game with you like mixed or mixed. mixed acidosis or mixed alkalosis, because you need to know the Winter's formula, which you're going to learn in term 4. So each quadrant has its own disease, I think. Yeah, whether it's respiratory acidosis, alkalosis, or metabolic acidosis and alkalosis. Put a star here on this slide. This is a very high yield. All right, guys. I think that's it for now. Did you talk about the drugs, like spironolactone, like for example, eplerenone, the drugs in your Nephron? Did you talk about that or no? You talk about that in your...
Sorry, I'm working out while doing this, but we didn't really go into drugs. We just have like 1 or 2 that are said for everything. So the only one I really know is like spirolactone or whatever.
Okay. Spironolactone is in your collecting duct. It acts on the principal cells. So remember the principal cell? You have the ENaC channels there. I think you're going to learn more about diuretics term 4. So for this one, for both of them, for exam, know the formulas. Memorize the formulas. Only one variable is missing. 2, histology. Do the Lippincott histology question book. Okay? The questions there for histology is high yield. Then redo the questions for anatomy. Do your Grace anatomy questions, please. Read the explanations carefully. 4th, if we have BRS physiology book, read that one. But I don't like the questions there. Why? Too easy. It's too easy questions. Do the pre-test physiology questions there. It's much more challenging. Okay? But for content, you can read the BRS physiology, except for the questions. What else? This is my advice. In the future, in term 2, right? Have a subscription for USMLE RX. I highly recommend that one. It's in sync with your first aid textbook, and as we all know, first aid is the Bible for your step 1 exam. So that's it for now. This is my last session for the year. Do you have any questions, guys? We're good?
No, thank you so much.
All right. So I'm going to post this on our Facebook page. I'm going to post both of the recordings on our YouTube channel. If you have any questions, you can DM me. You can post on our Facebook page. All right. Good luck, guys. Almost finished.
You.
One. Happy holidays. Okay.
You're the best, Nick. You too.
Oh, thank you so much. Have a good day, guys. See you. See you around.